Welcome. Hello, everyone. Welcome to the Assembly of Asia Pacific IAP 2021 webinar session. This is Dr. Polly Lam, President of the Hong Kong IAP. This webinar is the second AAP-IAP webinar since the COVID-19 pandemic, and it's the first one held by the Hong Kong IAP. I would like to let you know that we have over 1,000 registrants in this event. Today's webinar will have 4 lectures followed by a live Q&A session. The first lecture is by Professor Adrian Flanagan, Professor of Musculoskeletal Pathology, Department of Pathology, University College London. She is perhaps the most distinguished academic in this field, and she is also head of Department of Pathology, University College London. The title of her lecture is Update of WHO Classification of Bone Tumors. The second lecture is by Professor Keith Kerr from the Department of Pathology, Aberdeen University Medical School. Professor Kerr is a renowned international expert in lung cancer carcinogenesis and is one of the editors of the 5th edition of WHO Classification of Thoracic Tumors. He also spoke to us in the 30th Anniversary Congress. Today, he is going to speak to us on update of the WHO classification of thoracic tumors.
Good afternoon, everybody. I would like first to thank the organizing committee for organizing this great program of work. It's particularly difficult under these circumstances, but they have done a great job. I've been asked to speak to you and give you an update on the WHO classification of bone tumors. There's quite a lot new in the recent WHO book about bone tumors, so I won't be able to cover everything. But this is a list of the items that I will cover. I think that they're quite important. So we're going to start off with round cell tumors of bone. And for many years, well, the most common diagnosis we would think about once we've excluded things like lymphoma would be a Ewing sarcoma. For many years, there was always about 10% of cases that we could not identify EWSR1 rearrangements. But we now realize that these are accounted for by tumors with BCOR altered genomes and also CHIC altered genomes. And this accounts for the vast majority of such cases. In bone, BCOR alterations are much more common than CHIC alterations, which actually are quite uncommon. BCOR in bone generally fuses with cyclin B3, CCND3. And I've just shown you here some macroscopic descriptions of what you can see, typical bone tumors, quite cystic and soft. And you can see that the histology can be quite varied, a biphasic pattern here. That's just to highlight that the spectrum of histological features is quite diverse between tumors and in any tumor. This tumor does not harbor an EWS alteration, but instead expresses high levels of BCOR, and there is a good antibody for this. But it must be expressed strongly and diffusely in the nucleus for it to be used as for the diagnosis. If you're in doubt, one could look for the rearrangement by RT-PCR. FISH is not very valuable for identifying this alteration. Here I'm just showing you some of the general histological features that characterize a BCOR altered tumor, highlighting that there can be quite a disparate appearance. About 50% of these tumors express CD99, unlike Ewing's, where of course they should all express the CD99 extensively. The chick rearranged sarcomas are much more uncommon in bone. Again, they can express CD99, but it is often quite weak and patchy, and it's not always present. Here, there is not a very good antibody, but one can use FISH to identify the chick fusion gene. So I think that a round cell tumor now in bone requires a genetic alteration, as this will inform patients about the prognosis more accurately than without it. The next thing I will speak about is conventional cartilaginous tumors. And here we need to remember the role of the pathologist. We are providing classification in order to provide not only a diagnosis, but also prognosis. In well-differentiated tumors, which includes the benign, the enchondroma, and the osteochondroma in the bone and on the bone, respectively, and chondrosarcoma grade 1, it can be quite difficult to distinguish between these two levels of tumor, the benign and the low-grade malignancy. And so pathologists have used a wide variety of terms, including atypical cartilaginous tumors, well-differentiated and low-grade cartilaginous sarcomas, cellular enchondromas, and clump. Some people have actually used grade 1/2 chondrosarcoma. So now it's decided that we want to use one term for these, which is a typical cartilaginous tumor or a chondrosarcoma grade 1. And the outcome and management of these patients will be determined on the basis of the anatomical site. So location, location, location is what is important. This is a typical enchondroma, calcified in the bone, lots of matrix, calcified cartilage, which is represented in the radiology, and the nuclei are pycnotic and small. That's a typical enchondroma. But if the tumor is slightly more cellular, one wonders, is it a chondrosarcoma grade 1 or a benign tumor? But it's certainly a low-grade tumor. This has entrapment of host bone, as I'm pointing here, but also here. So once you have entrapment of host bone, one can classify it as malignant. But ultimately, these tumors are slow-growing and low-grade. However, if these tumors occur, these well-differentiated tumors, if they occur in the long bones or in the short bones of the hand and feet, they really have an excellent prognosis and can be curated. In contrast, if exactly the same tumor occurs in the skull, the base of skull, the clavicle, the scapula, the vertebral column, or the pelvic bones, so bones where it is difficult to remove all of the tumor, that tumor is therefore likely to recur multiple times in many cases. It may also progress to a higher grade, and these patients fare badly. And therefore, because of that, they are characterized with the term chondrosarcoma grade 1 because of their prognostic prediction. So it's all about location. So in summary, when you're considering making a diagnosis of a well-differentiated cartilaginous tumor, either in the bone or on the bone, think about location, location, location. If it's in the long bones or the small bones of the hands and feet, you call it an ACT, an atypical cartilaginous tumor. The outcome for the patient is very good, and it can be managed conservatively. However, if the same tumor is in parts of the body from where it is difficult to fully excise, this tumor is likely to recur, and the outcome is less favorable for the outcome. We use a similar type of nomenclature when we're talking about well-differentiated mature lipomatous tumors, which are characterized by MDM2 amplification. If such tumors are sited in the soft tissue and deep to fascia, where they can be easily excised, even if they're large, we call them atypical lipomatous tumors. However, if that same tumor is sited in the deep cavities of the chest, so the abdomen, the retroperitoneum, they are known as well-differentiated liposarcomas, because most of these patients will die of their disease. So remember to think about the role of the pathologist and what prognosis we can give to patients. So moving on, I now want to talk about some new molecular diagnostic markers that have been introduced into the recent WHO book. We're going to talk about chondroblastoma, synovial chondromatosis, soft tissue chondroma, and phosphaturic mesenchymal tumor, and they have a lot in common. So chondroblastoma, it's an osteoclast-rich tumor, but it also has cartilage deposited within it. And we now know that this tumor uniformly harbors a mutation, histone 3.3, with the variant K36M. And there is an excellent antibody, which is shown here on the screen. It's nuclear, it's crisp, it's clear, and it is present in all chondroblastomas. This has been valuable because we now are able to say that chondroblastomas rarely are seen in the jaws of the bone, the bones of the jaw. And also we can say that chondroblastoma rarely becomes malignant. It can be useful in diagnosing on small samples when you have a dominant part of a sample, such as a secondary aneurysmal cyst formation, but a small element of that lesion will actually be the primary tumor, which you may not be able to identify without this marker and make the correct diagnosis. So this is just a good example of the sensitivity and specificity of this marker. Synovial chondromatosis, again, a mature cartilaginous tumor, and you can see from the radiology a calcified or partly calcified mass behind the knee. The histology is lots of matrix, and this tumor is now, we can now say that in the vast majority of these tumors, they harbor a mutation, a rearrangement involving fibronectin 1, FN1, and it fuses in many cases with a gene which you see in colorectal cancer, ACVR2A. Although the rearrangement is only detected in 60%, this is an underestimate because of the structure of that rearrangement. These tumors have a great propensity to recur, mainly because they're difficult to excise fully. These tumors, in about 10% of cases, particularly in those cases after multiple recurrences, may become malignant. And the histology here is of a malignant tumor, mitotic activity, pleomorphism, but they still retain that alteration which is seen in the benign variant. So that doesn't help us with distinguishing benign from malignant synovial chondromatosis. A related tumor is the soft tissue chondroma. So this lesion occurs mainly in the hands and the feet. And it can be difficult to distinguish if it is associated with the synovium or actually separated independently in the soft tissue. That's because in the hands and feet, there's virtually no site at which you're far away from a tendon. But here we see an example. in the dorsal surface or the plantar surface of the foot, a small soft tissue lesion. The histology is of a cartilaginous tumor, very mature, lots of matrix, and no indication that it has a malignant feature. Soft tissue chondromas do not become malignant, and also they generally don't recur because they're buried in the soft tissue. They can be fully excised. So it is useful to be able to distinguish between these two lesions, the synovial chondromatosis and the soft tissue chondroma. There's also a separate variant of a soft tissue chondroma, and it was Andrew Rosenberg who described this some time ago, a chondroblastoma-like soft tissue chondroma. So it's partly calcified, and it has this grungy calcification, which is also seen in a chondroblastoma, hence the name that Andrew Rosenberg gave to this and has stood the test of time. Now, this then brings it into the realm and the differential diagnosis of a phosphaturic mesenchymal tumor, where you can also have this gungy, coarse calcification. But making a diagnosis of phosphaturic mesenchymal tumor and distinguishing it from a chondroblastoma-like soft tissue chondroma is important because of the systemic effects that a phosphaturic mesenchymal tumor mediates on the rest of the body. The phosphaturic mesenchymal tumor secretes large amounts of FGF23, giving rise to osteopenia and potential fractures, as we see in this, the chest ribs of this man, and also due to hypophosphatemia. So at a genetic level, the soft tissue chondroma, let me go back. The soft tissue chondroma harbors a rearrangement involving FN1, just like you see in synovial chondromatosis, but it doesn't have the ACVR2 gene fusing with it. Instead, we have the FGFR1 or the FGFR2. And interestingly, these same mutations are found, exactly the same mutations, for the most part, are found in phosphaturic mesenchymal tumor. However, the soft tissue chondroma does not secrete FGF23. So being able to distinguish between these lesions has an important role for treating the patient. So just to recap, remember that to use the word distinguish between atypical cartilaginous tumor and conventional chondrosarcoma grade 1 based on the anatomical site and the risk of recurrence. Remember the overlapping histological but one is able to differentiate between the tumors between a chondroblastoma, synovial chondromatosis, soft tissue chondroma, and a phosphaturic mesenchymal tumor. Now I'm going to talk about giant cell tumor of bone. Like the chondroblastoma, this also harbors a histone 3.3 gene mutation, but the variant is different from that seen in a chondroblastoma. Here, the vast majority harbor a G34W rearranged single nucleotide variant, and small numbers harbor a G34L, R, or M single nucleotide variant. This was published in 2013, and a few years later, a very good antibody was made available commercially to the common variant G34W. This accounts for about 96% of all what you're seeing in giant cell tumors of bone. Knowing that these tumors are now characterized by these alterations in the histone gene, one is able to say that one rarely sees a giant cell tumor of bone as a chondroblastoma in the jaws of, in the napic bones, the jaw bones. Instead, it's now reported by a number of people that the giant cell lesions in the jaw harbor alterations in genes involved in the MAP kinase pathway, such as RAS, FGFR1, NF mutations, and TRPV3. Just to go back here, this mutation is present in the mononuclear cells. It's a nuclear positivity that you see with this antibody. And the intervening cells here are osteoclasts, which do not harbor the mutation. And these are the osteoclasts down here, and these are CD68 positive cells. These are driven by whatever mutation is going on in the osteoprogenitor mononuclear cell population. With the discovery of this G34 mutation, and it's now published in the WHO book, we now can classify malignant variants of GCT more accurately. There's a conventional variant, a dedifferentiated, but you also see osteosarcomatous malignant GCTs and low-grade malignant GCTs. To point out some of these, this is the dedifferentiated variant. One shows here on the H&E an osteoclast-rich giant cell tumor of bone, which is the characteristic features, and confirmed by the presence of the mutant protein in the mononuclear cells. But one can see a very sharp delineation, highlighted particularly with the immunoslide, the complete absence of the mutant cells in the rest of this tumor. And there are no osteoclasts here, and the mutant protein is not seen. We now know, and this paper showing that many of these malignant GCTs have a mutation in hTERT. That was published following the publication of the WHO book. Secondly, this is another case of giant cell tumor of bone where it had pretty typical features, slightly atypical on the histology, and it was very odd that only scattered mononuclear cells, the tumor cells, showed immunoreactivity for the antibody. When the rest of the tumor was excised, in fact, it was completely devoid of mutant cells. And this tumor metastasized, and the patient has done badly. Now, clearly, in the absence of the mutant protein, one cannot make a diagnosis of a malignant GCT. It would be just classified as a malignant spindle cell or osteosarcomatous primary bone tumor. And this is a case, in fact, in this tumor, it shows osteosarcoma, and it is diffusely, I haven't put the immunoslide in, but this tumor was diffusely positive for G34W. So some cases which we previously would have described as classical osteosarcoma actually represent malignant
cancer carcinogenesis, and is one of the editors of the 5th edition of WHO classification of thoracic tumors. He also spoke to us in the 30th Anniversary Congress. Today, he's going to speak to us on update of the WHO classification of thoracic tumors.
And these are the typical features of a osteoblastoma, a surrounding rim of bone, and at low power, higher power magnification, you can see this is a highly vascular tumor with deposits of woven bone in between. Sometimes there's rather large plaques of bony deposits, but again, a highly vascularized tumors, and osteoclast can also be quite prominent. This rearrangement of FOS, which occurs in the majority of cases, FOSB is unusual. There is a good antibody to detect the overexpression, high levels of expression of FOS in osteoblastomas and in osteoid osteomas. Strong nuclear immunoreactivity. However, one needs to be cautious because occasionally one sees strong immunoreactivity, but it's very rare in osteosarcomas. But where this was seen, the morphology of the osteosarcoma was highly malignant and bore no resemblance to a typical osteoblastoma. And this is an example of the immunohistochemistry seen in an osteoid osteoma. A small lesion. I'd like to remind you that the difference between an osteoid and an osteoid osteoma and osteoblastoma is arbitrarily defined by the size of 2 centimeters. And what is striking is that the number of neoplastic cells is defined, highlighted by these immunoreactive cells, actually is quite limited. And here is just showing an osteoblastoma where we have the immunoreactive cells and again the osteoblastoma. This work was published in 2019 in AMJ Surg Palp. But it can be helpful. This is a young man, an unusual tumor in the finger. And it fractured and then was curetted and then recurred and was behaving quite aggressively. There was even entrapment of host bone, which was very concerning. And some of the histology was not typical of a osteoblastoma. However, the immunoreactivity was very strong and convincing, and a rearrangement of the false rearrangement was detected as well. Therefore, one could give a confident diagnosis of an osteoblastoma. However, just to highlight that in about 14% of osteosarcomas, there is focal, usually weak immunoreactivity for FOS, and also there's about 20% of osteoblastomas that are completely negative. So one needs to use this antibody and this information cautiously in the context of the histology, but also in the context of the clinical findings, and particularly the radiology. But notwithstanding that, it is a good marker. Very recently, in the last month, I think, the same FOS rearrangement and expression of the immunoprotein has been reported in cementoblastomas. These are lesions in the jaw, and this is Daniel Baumhauer's work, showing that these overlap and essentially are the same tumor as osteoblastoma. So that is also a new, this was not published in the WHO book, but is an update since then. I'd now like to talk about another tumor, which was not published in the WHO book, but has since come out, but I think it's worth highlighting to you. This is an EWSR1 SMAD3 fibroblastic tumor of bone. This tumor was originally reported in soft tissue in 2018. The tumors there in the soft tissue are usually small, subcutaneous or dermal, and are considered to be benign lesions. This was a case that we had in-house that we reported in 2012. Quite honestly, we didn't know what the diagnosis was. Radiologically, it actually was quite an aggressive tumor, which made everybody quite concerned about how to treat this young person. However, the histology was very mixed. Some cartilaginous differentiation, and these swirls of fibrous tissue, the mitotic activity was low. And the decision was made in discussion with the parents not to treat the patient with chemotherapy, and they had the tumor excised. We had the opportunity to go back and undertake whole genome sequencing on this tumor, and we were now able to make this diagnosis. So these SMAD3 tumors do occur in bone, and they're rare. But this patient actually is now alive 8 years after his operation. He had a prosthesis put in, and there's been no recurrence. So obviously we need to keep an eye on this. It may be that they are locally aggressive, but they're rare, and we don't have that information as yet. So just to recap on everything that we've discussed, we need to talk about the cartilaginous tumors, the low-grade, well-differentiated tumors, the terminology you use is based on the anatomical site. If they're in the long bones or the small bones of the hands and feet, they're atypical cartilaginous tumors with an excellent prognosis. In the spine, the pelvis, where tumors are difficult to excise, call them chondrosarcoma grade 1, as the patients it's not a favorable outcome. Round cell tumors of the bone, if you do not detect an EWS-R1 rearrangement for a Ewing sarcoma, consider a B-core rearrangement or a CHIP rearrangement. There's a very good antibody for B-core. If in doubt, use RT-PCR or some other molecular marker to define that rearrangement. And these are CHIP rearrangements are very rare in bone, but it's worth, again, undertaking the molecular diagnosis. Cartilaginous tumors, chondroblastomas, harbor in virtually all cases, a histone 3.3, K36M mutation, and giant cell tumors of bone, AG34W mutation. There's excellent antibodies here to be able to demonstrate these alterations and provide a robust diagnosis. Chondroblastomas can look like the chondroblastoma-like soft tissue chondroma and phosphaturic mesenchymal tumor, and these can be distinguished with the antibody K36M, but also the rearrangements in synovial chondromatosis and soft tissue chondroma. FOS rearrangements can be very valuable to distinguish osteoblastoma and osteoid osteoma from osteosarcoma. One can use FISH, but also an antibody. And finally, very rarely, we have identified an EWSR1 rearrangement with SMAD in a fibroblastic tumor of bone, and which seems to be identical to that seen in soft tissue. And so with that, I would like to thank you for your attention, and I would like to thank the funders, but also I would like to thank specifically Professor Ian Cray, who was the head of the WHO tumor classification my co-authors of the Blue Book on Bone, and my colleagues who did a lot of work on the WHO book as well. Thank you very much for your attention.
Hello there, my name is Keith Kerr. I'm a consultant pathologist in Aberdeen at the University Medical School and also in Aberdeen Royal Infirmary. It's my great pleasure to join you for this symposium, and my task is to discuss the WHO classification of tumours of the lung. As you may be aware, the 5th edition of the WHO classification was very recently published from the IARC in Lyon. I should also say thank you very much to the Hong Kong division of the IAP, and particularly to Gary for the invitation to speak to you today. This work is the result of a lot of collaboration between the Standing Committee of the IARC WHO group and also a group of specialist pathologists, largely represented by the IASLC Pathology Committee. The classification of lung tumours is one part of quite a large book, which, as I mentioned, has just been published. And because of limitations of time, I'm going to have to be very superficial in what I say. The pulmonary sections of the classification involve the 5 categories that are listed here, and I'm going to spend the vast majority of the talk on the first 2 categories. Very little has actually changed as far as the WHO classification of lung tumours is concerned in this particular iteration. The book itself shows some structural changes from previous products, and in particular, both essential and desirable criteria are provided for each of the entities that are described in the book. Some of these lists of criteria are quite long, and whilst I'll include them in my slides for your reference down the line, I'm really not going to be able to go through these criteria in any detail. Small changes to the classification include the formal recognition of the SMARC deficient tumours. Bronchiolar adenoma has been added to the list of adenomas. Our old friend LELC has been changed. It's had its name changed to lymphoepithelial carcinoma, I beg your pardon. And we've also changed the name of enteric type adenocarcinoma. We also note the changes that the TNM8 classification has made for lipidic predominant adenocarcinomas in terms of their staging, and I'll discuss that very briefly as we go along. You should also note that in the same book there are many other chapters or sections discussing many other thoracic type tumours. So let's begin with the section in adenomas. This is the first section in the book, and there are 5 adenomas or types of adenoma that were previously listed in the classification. But as I mentioned, bronchiolar adenoma, formerly known but still validly known as ciliated muconodular papillary tumor, is a new addition. And this is an interesting but rare tumor which appears to occur in the peripheral part of the lung, and morphologically is very similar to what we have recognized for a long time in the lung and described as peribronchiolar metaplasia. So we have these papillary proliferations of benign-looking epithelium And the characteristic feature in this proliferation is the dual cell population, which may be identified by immunohistochemistry, showing a population of both basal cells, which are positive with P40 and CK56, and also CK7 positive columnar cells, many of which may be ciliated. I've put in this slide for comparison a rather low-grade papillary adenocarcinoma, which does not show the basal layer by CK56 or P40 immunohistochemistry. An interesting thing about these bronchiolar adenomas is that many of them actually show significant mutations. About half of them have BRAF V600 mutations, and a smaller proportion have EGFR mutations. So moving on to the next section, which is adenocarcinoma. Again, very little significant change here. But I'm just going to take you through the lesions in the putative progression of at least some adenocarcinoma lesions, starting with what we might consider as a benign precursor atypical adenomatous hyperplasia, into adenocarcinoma in situ, then minimally invasive adenocarcinoma, and then invasive non-mucinous adenocarcinoma, before discussing the four special types of adenocarcinoma at the end of this section. So atypical adenomatous hyperplasia, or AAH, is a small centriacinar lesion, generally an incidental finding on histological examination, and most of these lesions measure less than 5 millimeters. And they're characterized by thickening of the alveolar walls and an increase in the number of type 2 pneumocytes, showing mild atypia. One of the characteristic features of these lesions is that the cell lining population generally is intermittent, with gaps visible between the cells. And this is in distinction to adenocarcinoma in situ. Now, adenocarcinoma in situ is again a localized lesion, which by definition, strictly driven by the availability of data, is a lesion which is 30 millimeters or less in size and shows a pure lipidic growth with a continuous lining of what now look like adenocarcinoma cells. So no evidence of any form of invasion or invasive pattern of adenocarcinoma, no evidence of any special type of adenocarcinoma, and a lesion which is localized and less than 30 millimeters across. When invasion does occur in such a lesion, but the extent of invasion according to the measured size is less than or equal to 5 millimeters in a single focus, or less than or equal to 5 millimeters in aggregate, and I'll discuss the aggregation later on, then we have, by definition, something called minimally invasive adenocarcinoma. Minimally invasive adenocarcinoma was a category which was created because it was realized that we can have lipidic predominant adenocarcinomas with tiny amounts of invasive disease, but still apparently no metastatic potential and a 5-year survival of 100%. And here is an example of such a lesion on gross examination. And then on histology, we see a predominantly lipidic lesion, but in that central area of more solid appearance, there are histological features of invasive patterns of adenocarcinoma. But this focus still measured, this single focus, less than 5 millimeters across. If the invasive component accounts for more than 5 millimeters in the lesion, then we have the traditional form of invasive non-mucinous adenocarcinoma. And of course, many of these lesions still may have a lipidic component. The vast majority of these lesions are mixtures of patterns, which may include lipidic, acinar pattern adenocarcinoma, papillary pattern adenocarcinoma, micropapillary pattern adenocarcinoma, which can range on the left from the classical starburst, grape-like tufts of adenocarcinoma cells, often occupying spaces which may be acinar alveolar spaces or maybe newly formed spaces in the tumor. But also the tumor might be composed of more strand or cord-like groups of adenocarcinoma cells protruding into the space within the lesion. Then there is solid pattern adenocarcinoma, which shows none of the architectural patterns of differentiation, but we recognize the adenocarcinoma either by the presence of mucin, characterized by at least 5 mucin-containing tumor cells in at least 2 high-power fields. So quite a low bar to cover for mucin expression. But more recently, we included as an alternative, as well as an additional finding, the presence of staining for type 2 pneumocyte-associated antigens. And in practice, this essentially means TTF1 positivity in the tumor. Recently, the ISLC Pathology Committee published a refinement of the recommendations for reporting the predominant pattern, recognizing that the predominant pattern does have prognostic significance. This refinement for grading still considered the predominant pattern, but also the presence of a secondary pattern if it is one of the high-grade patterns, that is solid or micropapillary, or also a complex glandular pattern of adenocarcinoma. In other words, de facto cribriform pattern, although that has not been formally recognized in the classification so far. This new grading system, looking at both the predominant pattern and the presence or absence of a lesser amount of high-grade disease with a 20% cutoff, seems to give us an even better separation and an even better grading system. And as far as the staging system is concerned, I mentioned before that in TNM8, for non-mucinous adenocarcinomas, it should only be the invasive components of the tumor that are measured to determine T size. In other words, the lipidic component of any tumor should not be included in the measurement. And this means that the lipidic component should be ignored, and the invasive component or components, either as a single area, should be measured, or if there are multiple areas of invasion within an otherwise lipidic tumor, then the proportion of the lesion that comprises those invasive components should be multiplied by the maximum size of the tumor to derive the T stage size. And again, therefore, the 5 millimeter threshold and above applies for invasive non-mucinous adenocarcinoma. Of the special types of adenocarcinoma that are invasive, invasive mucinous adenocarcinoma is really, I'd say, by far the commonest type of tumor. And this tumor is characterized by a proliferation of relatively well-differentiated mucin-secreting adenocarcinoma cells, columnar in shape. Often goblet cells are present, and usually in these tumors, there is a lipidic component to the tumor which is dominant, and these lesions are often multifocal. Indeed, you might struggle to find evidence of the invasive component, which is usually either strands of single cells or acinar disease in the context of an often fibroblastic stroma. Classically, these tumors also tend to spread in the lung, as well as the multifocality. They also give a pneumonic type consolidation to the tumor, to the lung, which is very characteristic radiologically and may indeed be mistaken for a diagnosis of pneumonia. These tumors vary in their immunophenotype. Quite often TTF1 is negative, and sometimes they can show quite a strong enteric phenotype, with CK20 and or CDX2, which can lead to diagnostic complications. But remember, this is readily diagnosable as a primary lung adenocarcinoma. A less common type of adenocarcinoma of the lung is colloid adenocarcinoma, which again may often show an enteric histological immunophenotype. And otherwise, from a morphological point of view, is just like the colloid adenocarcinomas that occur in the colon or in the breast, for example, with pools of mucin filling alveolar spaces with little reaction and often only small clusters of tumor cells. Rarer still is the fetal adenocarcinoma of the lung, which in morphological terms may resemble rather well differentiated endometrioid adenocarcinoma and which may have squamous memorial formation. A diagnostic assist, particularly in the better differentiated forms, is the presence of nuclear beta-catenin expression. Enteric type adenocarcinoma is also an uncommon diagnosis, at least in my experience, and these lesions closely resemble colorectal carcinoma, and therefore we may have a differential diagnostic problem with metastatic colorectal cancer. In my experience, metastatic colorectal cancer is far more common than enteric type primary adenocarcinoma of the lung. Just to complicate matters, the primary enteric type adenocarcinoma of the lung also has an enteric phenotype expressing CK20 and CDX2, but CK7 expression may well be retained. And there is preliminary evidence that SATB2, which is usually strongly expressed in colorectal cancer, may not be strongly expressed in the primary lung tumors. So moving quickly on to squamous lesions, the precursor lesions of dysplasia and carcinoma, I'm not going to discuss. Absolutely nothing has changed about them. In terms of the family of squamous cell carcinomas, we have squamous cell carcinoma, and now lymphoepithelial carcinoma has been included in this family. As far as the squamous cell tumors are concerned, we have keratinizing squamous cell carcinoma, which in a resection specimen is an H&E diagnosis. We have non-keratinizing squamous cell carcinoma, which in a resection specimen is an immunohistochemical diagnosis derived from an undifferentiated tumor. And then we have basaloid squamous cell carcinoma, which is again an H&E diagnosis. In addition to these, we now have our friend lymphoepithelial carcinoma of the lung, a lesion which in my practice is exceptionally rare, but I know in your practice is not at all a rare tumor. And in your practice in particular is usually an EBV-driven malignancy. So morphological definitions of squamous cell carcinoma require evidence of keratinization in the form of intercellular bridges or individual cell keratinization. But we've also accepted, as you well know, immunohistochemical evidence of the expression of markers which are associated with squamous cell differentiation, therein, for all practical purposes, P40 expression. In the resection specimen, therefore, which has an morphologically undifferentiated carcinoma, which has been well sampled, we perform immunohistochemistry, and we'll come back to this issue in a moment. And if P40 is strongly and widely expressed, then you're entitled to diagnose non-keratinizing squamous cell carcinoma. Basaloid carcinoma is a morphological diagnosis where very typical appearances with islands of tumor cells showing peripheral palisading, often these small abrupt foci of keratinization without those large glassy eosinophilic intermediate keratinizing cells. And often in my experience, the intercellular spaces often showing stainable basement membrane type material. And we make a diagnosis of basaloid squamous cell carcinoma if these appearances are present in at least half of the tumor. Lymphoepithelial carcinoma of the lung, as you well know, is a tumor comprising of large pleomorphic malignant cells in a rather syncytial diffuse arrangement, intimately admixed with a lymphoid cell infiltrate. These tumors express the squamous associated markers, hence the placement of this tumor now in the squamous family. And most of these lesions, as you know, are EBV associated. The next group of epithelial, or two groups of epithelial tumors that I would like to discuss are the undifferentiated tumors, large cell carcinoma, and also sarcomatoid carcinoma, or at least the pleomorphic carcinomas as part of the sarcomatoid carcinomas. I've decided not to discuss blastoma or carcinoma sarcoma in the interest of time. Nothing has changed about the classification of blastoma or carcinosarcoma. Large cell carcinoma then is a tumor which is not small cell carcinoma, and it completely lacks any morphological evidence of differentiation. And the thinking now is that either squamous cell carcinoma or adenocarcinomas, perhaps as these tumors progress and grow, they may de-differentiate. In fact, I think in my experience, I think most squamous and adenocarcinomas, as they grow and progress, they probably do de-differentiate. And at some point, the tumor will lose its morphological H&E evidence of differentiation. And therefore, at a morphological level, we have large cell carcinoma. But we've also learned that in this group of morphologically defined large cell carcinomas, if we perform our immunohistochemical stains that we associate with either squamous lineage or adenocarcinoma lineage, and in practice this is P40 or TTF1, we know that a proportion of these cases will be positive for either of those markers. In my experience, almost half of these tumors are P40 positive with a squamous lineage. This might be a bit less so in your experience, where adenocarcinoma lineage may be a bit more common in the undifferentiated resected tumors. But in my experience, about a third of these cases either show no immunohistochemical staining or do not show a determinate, definitive immunophenotype. And in those cases, we are entitled to diagnose, even after immunohistochemistry, large cell carcinoma. So we've removed from the large cell category non-keratinizing squamous cell carcinoma and some of the solid pattern adenocarcinomas that would have not been diagnosed by a mucin stain. Note at the bottom of this slide, therefore, the diagnosis of large cell carcinoma is only made after immunohistochemistry is carried out and is either negative completely or is indeterminate or unclear, or it was not possible to carry out immunohistochemistry. Pleomorphic carcinoma of the lung is a tumor defined by the presence of at least 10% of the resected specimen after adequate sampling, comprising spindle cell tumor cells, giant cell tumor cells, or very pleomorphic tumor cells. The tumor may be entirely composed of such spindle or neoplastic giant cells, but more commonly, it is only a proportion of the tumor that is made up of this component, although always, by definition, more than 10%, admixed with a differentiated type of tumor. So here is an example, and this is probably marginally more commoner in my practice, of pleomorphic carcinoma with huge tumor cells with huge pleomorphic nuclei, but also a spindle cell component, but also differentiated squamous cell carcinoma. Here is an example of adenocarcinoma, which also shows areas of spindle cell carcinoma and also very pleomorphic carcinoma. One of the tips that I could give you for considering something as a pleomorphic carcinoma area is when very large nuclei really stand out when you scan the slide at times for magnification objective. As I mentioned, it's rarer for tumors to comprise purely of spindle cell carcinoma or very pleomorphic carcinoma or giant cell carcinoma. And in this latter pattern of disease, it's also very common to see neutrophil polymorph emperipolesis into the tumor cells. Other forms of epithelial tumor include adenosquamous carcinoma, which I'll discuss in a moment. But I also want to just very briefly highlight nut-associated carcinoma of the lung or thorax. And indeed, in the book, this is not in the lung section, it's in the thorax section, but we do see these tumors involving the lung. This was in the previous classification, but I just want to mention it to you as a very poorly differentiated cancer, sometimes with a basaloid appearance, which has the NUT M1 gene rearrangement, and which is associated with immunohistochemical positivity for NUT protein in at least half of the tumor cell nuclei. Now properly defined in the classification is thoracic SMARCA4 deficient undifferentiated tumor. There's been some slight controversy about whether this tumor should be called a carcinoma or a sarcoma. So we've ducked the issue in a way and called it an undifferentiated tumor. These tumors often have a rhabdoid appearance, albeit with morphological undifferentiated appearances, but typically show only very focal staining for pancytokeratins. And if the staining is strong and diffuse, it's probably not one of these tumors. They are characterized by the loss of SMARCA4 or BRG1 on immunohistochemistry. And some of these tumors, it's worth noting, have juxtaposed with them a more recognizable pattern of non-small cell carcinoma. Whilst at the moment SMARCA4 deficient tumors have no therapeutic implications, there is some emerging evidence that there may be specific inhibitors for NUT carcinoma, but these are far from being approved in the clinic. Adenosquamous carcinoma, by definition, is a tumor in a resection specimen, which is composed of both recognizable squamous carcinoma and also adenocarcinoma, where each component makes up at least 10% of the tumor. So I emphasize to you, this is a diagnosis about which you can only be certain in a resection specimen, where you can recognize morphologically more often than not adenocarcinoma components and also squamous carcinoma components. We might confirm this diagnosis or make ourselves a bit happier about this diagnosis by using appropriate immunohistochemistry, and that this is fair. But we also have to consider the possibility of making this diagnosis in an undifferentiated tumor where we've applied the immunohistochemistry as we would do by rights and find that there are very definitive areas of both adenocarcinoma and squamous cell carcinoma at an immunohistochemical level. I will not pretend that this is a simple job if you're ever faced with this task. And I think you just have to assess the evidence and then take a decision and make your diagnosis. Just briefly, I want to point out to you that it's quite common in some particularly more peripherally located squamous cell carcinomas in the lung that alveolar walls may become entrapped within the tumor and the alveolar pneumocytes become hyperproliferative and very prominent. In these situations, we may see what appear to be glands within a squamous cell carcinoma, but you must not diagnose adenosquamous carcinoma in these circumstances. This is simply entrapment of benign alveolar walls within a squamous cell carcinoma. But it's a common trap and pitfall for an erroneous diagnosis of adenosquamous carcinoma. Nothing has changed in the category of salivary gland type tumors in the lung, so I'm not going to discuss any of these because they are as they were previously, and these are pretty uncommon tumors, many of whom occur predominantly in the very large bronchi or indeed in the lower trachea. Coming to neuroendocrine neoplasms, this has been a structural change in the classification in the sense that these tumors have now been put into one section, in one family, as it were, and include the precursor lesion, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, much easier to call it DIPNEC, and also neuroendocrine tumors, which really make up the family of carcinoid tumors in the lung, and then the neuroendocrine carcinomas in the lung, which are small cell carcinoma and large cell neuroendocrine carcinoma. So beginning with DIPNEC, a rare condition, but actually I suspect an under-recognized condition where there is diffuse proliferation of neuroendocrine cells in the lung in the form of increased numbers of airway basally located neuroendocrine cells, best identified by a chromogranin immunohistochemistry. But sometimes these proliferations cause nodular protrusions into the small airway lumen, so-called neuroendocrine nodules or bodies. And then when these neuroendocrine cells extend beyond the basement membrane of the bronchiolar epithelium, we have by definition a carcinoid tumorlet, which a lesion which is often associated with a bit of fibroplasia associated with those neuroendocrine cells. And those carcinoid tumorlets in DIPNEC are often very numerous. But if any carcinoid tumorlet attains a size of greater than 5 millimeters, by definition, the lesion has to be regarded as a carcinoid tumor. And these carcinoid tumors are therefore usually, overwhelmingly, I would say, in DIPNEC, of the spindle cell type. So carcinoid tumors have not changed, but we also acknowledge that we can call them neuroendocrine tumors of the lung. But carcinoid tumor is by far the preferred terminology, and the diagnostic criteria have not changed. These tumors look like low-grade neuroendocrine tumors. They have a carcinoid appearance, which I'll show you in a moment, but it is the mitotic counts and or the presence of punctate necrosis that helps us to differentiate carcinoids from atypical carcinoids. Macroscopically, these lesions are usually centrally located and cause bronchial obstruction, often long-standing bronchial obstruction, which can lead to very spectacular changes in the peripheral lung in the resection specimen. And the typical appearances are of the insular or trabecular patterns, sometimes with rosette formation of low-grade neuroendocrine cells with round nuclei and a fine stippled chromatin with a mitotic count which does not exceed 2 in 2 millimeters squared of counted tumor, even counting hotspots, and no evidence of necrosis. These tumors sometimes have a rather hyalinized stroma, which may contain bone, and these tumors often, when centrally located, are associated with a thin, low-grade squamous metaplasia over the surface of the tumor. Sometimes they are peripherally located, even in the absence of evidence of DIPNEC, and have spindle cell morphology. Atypical carcinoids are tumors which have a mitotic count between 2 and 10 per 2 millimeters squared and or have evidence of punctate necrosis. Of the carcinomas, small cell carcinoma is by far the commonest type of tumor, illustrated here as a very high-grade malignant tumor comprising small cells with very typical nuclear features, nuclear molding, high mitotic and apoptotic weight, and very little in the way of cytoplasm. In biopsy and cytology material, these lesions have very typical appearances and are often very easy to recognize, even with very poor or very scant material for diagnosis. Immunohistochemically, these lesions will express neuroendocrine markers. CD56 is often the best expressed, but you must remember that this is the least specific marker. And many non-small cell tumors, particularly squamous cell carcinomas, may express CD56. Synaptophysin is the most reliable marker in terms of balancing sensitivity and specificity. And whilst it's quite nice to get a chromogranin positivity if you need neuroendocrine markers to make your diagnosis, not infrequently in my experience, bona fide small cell carcinomas do not express chromogranin. And indeed, it begs the question, do we need immunohistochemistry to make a diagnosis of small cell carcinoma? And the answer is actually no, we don't, but we tend to use it just to make us feel a bit happier about making the diagnosis. In contrast, however, if we're going to make a diagnosis of large cell neuroendocrine carcinoma, we do need evidence of neuroendocrine differentiation. And for all practical purposes, this is immunohistochemical evidence. Large cell neuroendocrine carcinoma also morphologically, looks like a neuroendocrine tumor. More of these lesions appear to occur in the periphery of the lung than centrally, but they can occur centrally, of course. And classically, they have this appearance with typical neuroendocrine type differentiation with rosette formation, trabecular architecture, peripheral palisading when we have islands of tumor cells, and comedo type necrosis with a high mitotic rate and many apoptotic figures. By definition, the mitotic count will be greater than 10 mitotic figures per 2 millimeters squared, but in practice, the count is often 60 or 70 or even more. We need evidence of immunohistochemical differentiation, and preferably it will be two of the markers, CD56 and synaptophysin, majoring here, but not infrequently you also find chromogranin staining. Remember also that these lesions are TTF1 expressing in probably 50% to 60%. Also do remember that about 90% of small cell carcinomas express TTF1. And this collective expression of TTF1 in neuroendocrine tumors, you must remember when there is a danger of mixing these lesions up with adenocarcinoma. Large cell neuroendocrine carcinomas can be admixed with adenocarcinoma. In my experience, about a third of my LC-NEC cases have adenocarcinoma components. Less commonly with squamous cell carcinoma, and less commonly again with small cell carcinoma. Which brings me towards the end of the presentation very briefly to talk about the diagnosis and classification in small samples. We fought very hard and we succeeded in persuading the editorial committee that we should have this category in the book. And I think this is very important. As I've mentioned, the diagnosis of small cell carcinoma by morphology is generally very reliable. On the other hand, subclassification of non-small cell carcinomas by morphology is not very reliable in between a third and up to 40% of cases in small biopsy and cytology material. And we all know the issues here, the fact that morphological evidence at an architectural level for adenocarcinoma or at a cellular level for squamous carcinoma may be lacking in those tiny biopsies with little tumour or in some of our cytology samples, where morphologically, therefore, the diagnosis is non-small cell carcinoma, not otherwise specified. But we also learned that by using P40 and TTF1 immunohistochemistry, we can reduce the number of cases which still defy classification after immunohistochemistry, down from 25 to 40% of cases, down to certainly, I would say, less than 10% of the cases that you are diagnosing. And here's a couple of examples of such refinement of the diagnosis. And therefore, the terminology has been retained in the WHO classification, where those cases which have been refined by immunohistochemistry in the small sample diagnoses on the left of your screen are favored the diagnosis favoring squamous or favoring adenocarcinoma, where the diagnosis is still non-small cell carcinoma. And it is still legitimate in the small number of cases to give a diagnosis of non-small cell NOS if you've carried out your immunohistochemistry and not found proper staining. I've mentioned these things, but just briefly, diagnosing non-small cell NOS too often should not occur. We should indicate that we've used immunohistochemistry in our diagnosis. Please don't get drawn into using the categorization of non-squamous non-small cell carcinoma, and be aware of the diagnosis that you cannot make on small biopsies, such as adenocarcinoma in situ, pleomorphic carcinoma, adenosquamous carcinoma, and large cell carcinoma. I have nothing to say about tumors of ectopic tissue, which are vanishingly rare in the lung, as are many of the mesenchymal tumors that are specific to the lung. But I just want to draw your attention to two of these. The commonest, which is pulmonary hamartoma. I draw your attention to this lesion simply to remind you that whilst most of these lesions are peripherally located in the lung and may be confidently diagnosed by the radiologist and then excised by the surgeon, these lesions may also be endobronchial and can be mistaken for an endobronchial carcinoma. You can also make a diagnosis if you're careful and aware of this phenomenon of endobronchial hamartoma on a bronchial biopsy sample. A much rarer lesion is primary pulmonary myxoid sarcoma, which has this loose myxoid, rather characteristic morphology, and the diagnosis then is confirmed by confirming the presence of the EWSR1 CREB1 fusion gene. Finally, hematolymphoid tumors, again, relatively uncommon in the lung, but just one illustrate pulmonary Langerhans cell histiocytosis, an interesting lesion in the lung, which is probably different from a biological point of view from the Langerhans cell tumors that occur in childhood and in other circumstances. This is a strongly smoking-associated proliferation of CD1A positive cells associated with eosinophils, which has a very characteristic appearance in the lung, but actually which can be mistakenly diagnosed or missed when the lesions become very fibrotic and begin to turn into centriacinar scarred lesions, which can be missed, and therefore the diagnosis of Langerhans cell histiocytosis not made in a pulmonary biopsy. So I am finished. I would like to thank you very much for your attention, and it's goodbye from me in Aberdeen to you guys quite close to Aberdeen in Hong Kong. Thank you very much indeed for your attention.
We're going to take a break of 5 minutes. See you later. Welcome back to the second half of the webinar. The third lecture is by Professor H.K. Ng, Chair Professor of Pathology, the Chinese University of Hong Kong. Professor Ng needs no introduction. He is one of the only 10 neuropathologists from around the world who have been selected for the consensus group for the WHO 2020 classification of CNS tumors. The title of his lecture is A Very Brief Summary of What is New in WHO 2021 Central Nervous System.
Hello, for those of you who would want a screen, would want to have the full update PowerPoint, you can obtain at this website, or you can screen capture this PowerPoint or take a photo. So hello, this is H.K. Ng. This is the lecture on the WHO classification of the central nervous systems. I'm from the Chinese University of Hong Kong. So I'm sorry this is going to be a slightly boring talk, as 45 minutes are not really enough to discuss fully the entire CNS classification, as we have many more entities than other systems. So there's only enough time to read through the entire classification, just to read through. And parts of the classification which do not have many changes will not be dealt with. As I mentioned, there are just too many entities compared to other organ systems. Also, the WHO Blue Book on Brain Tumors includes a section on hereditary brain tumor syndromes, which I will not discuss. Some of the entities I mentioned today I've not seen myself, so I'm sorry I cannot really illustrate with slides everything that is mentioned. The WHO classification of brain tumors should be imminently in print at the latest in June, and I would recommend you to look out for the summary which we wrote together with the first author being David Lewis, and it will be published simultaneously with the WHO classification in neuro-oncology, so look out for it. So there's anything you don't like, please don't shoot me. The WHO classification this time, like other organ systems, is led by a smaller group of pathologists, and I'm very lucky, privileged to be in a group, and we have 2 clinicians. And like other organ systems, when we do the writing of the sections and the chapters, many other pathologists were involved, and many clinicians, neurosurgeons, oncologists, scientists were involved also. I'm sorry, this is how we met online in our consensus meeting. Everybody is looking tired and unhappy in the middle of the night, you can see, but this is the new norm. So just a few words about some general changes. Pediatric, in the new classification now, pediatric and adult gliomas are separate. The grading has been changed to Arabic numericals 1, 2, 3, 4, and not Roman numericals 1, 2, 3, 4. So to conform to the other systems. Grading is within each tumor group and not across all brain tumors. Within each tumor group, within glioma, within meningioma, for example. Methylomes, the methylomes is a very useful diagnostic tool in many new and rare lesions and have been incorporated as a desirable diagnostic criteria. I'll go into the methylome more in the next PowerPoints. We appreciate that some tumors, when you diagnose them in a day-to-day practice, may not fulfill all the molecular pathology that is described. Excuse me. So we call them not elsewhere classified. For example, you may be seeing a histologically typical lesion of something, but it does not have all the molecular features that is described in the blue book, so it's not elsewhere classified. We recommend integrated diagnosis, integrating molecular, histological, and grading in the daily practice, which we recommended back in 2014, which we call Harlem recommendation or consensus, incorporation of biomarker into integrated diagnoses for brain tumors. Very briefly, whole genome methylation profiling. The process is now very streamlined. We almost all use the Illumina chips of 850K or 450K, and from which binary ID80 files are generated, and you can upload the file, the data, into the German Cancer Center website, or called DKAppZ, from which they will tell you a probable diagnosis with a confidence score, but they maintain that you do need a high confidence score to be sure of the diagnosis. Alternatively, you can create your own methylation diagnosis by what is called the kappa plot, or the the TSNE plot, the kappa. So the DKApp, you said, folks, wrote a very important paper in Nature 3 years ago, by which they used the methylation profile and the bioinformatic plot called TSNE, from which they are able to create a map of 140 brain tumors you can possibly see in the nervous system out of 3,000 cases, I think something like that. So it is a histological diagnosis without histology. And this methylation profiling, as I mentioned, is listed as the diagnostic criteria in the classification for many entities. If you have the bioinformatic tool after the ID80 file, you can create your own TSNE plot too. This is, for example, this is what we have done, and you can see this is our own plot mapped against the kappa map. The cursor doesn't show up very well in our system, but you can see the triangles are own cases, and the blue and the circles, blue, gray, red, and so on, are the background from the kappa map. So you can do it yourself, the methylation diagnosis. The methylomes can also give you complete in addition to the diagnosis, the methylomes can also give you the complete cytogenetic picture, as you can see on the left hand side, the arm level amplification, and the arm level deletion. and arm level deletion, and you can also create on the right hand side gene level amplification and deletion. This is what the methylomes give you in addition. The methylomes can give you the MGMT information, the 1p19q status, and the so-called GCIMP status, which is GCIMP stands for glioma CpG island methylation phenotype, which in our circle, as you can see on the right-hand side of the screen, the cursor doesn't work very well, I'm sorry. The GCIMP can give you very useful prognostic status in gliomas. So now into the details of the classification. As I mentioned, pediatric, adult, separate. So I'll just read out as I mentioned, it's kind of difficult. I'll just read out first. Pediatric type diffuse low-grade glioma, diffuse astrocytoma, MIG-L1 altered angiocentric glioma, diffuse low-grade glioma, MAP altered, polymorphous low-grade neuroepithelial tumor of the young, or sometimes called plenty, pediatric type diffuse high-grade gliomas, diffuse midline glioma, H3K27M mutant, diffuse hemispheric glioma, H3G34 mutant, diffuse pediatric type high-grade glioma, H3 wild type and IDH wild type, and diffuse midline glioma, EGFR mutant, and infant type hemispheric glioma, H3 wild type. Now, for these two big groups, I want to draw you to the words diffuse and yet low grade. Now, in the past, in previous WHO classification, diffuse is grade 2 and therefore low grade malignant. But not so much here. I'll show you in a minute. The pediatric type diffuse gliomas are still low grade. And then we come on to the group you're all familiar with, the circumscribed astrocytic gliomas, pilocytic astrocytoma, high-grade astrocytoma with pyloid features, pleomorphic central astrocytoma, subependymal giant cell astrocytoma, chordoid glioma, Osteoblastoma MN1 altered, and then a list of the Glio-neuronal tumor, ganglioglioma, desmoplastic, infantile astrocytoma, ganglioglioma, dysembryoplastic neuroepithelial tumor, diffuse Glio-neuronal tumor with oligonucleoma-like features and nuclear dust, papillary Glio-neuronal tumor, diffuse leptomeningeal Glio-neuronal tumor. Now, this is a very important paper published by Mini Bandyopadhyay some years ago, a meta-analysis of pediatric gliomas of a large number of cases, 4,000 cases. As you can see, when we call them grade 1 or 2, the prognosis does not differ too much. So even when we call them diffuse glioma in children, the survival is 400 months, over 400 months. Survival is still very good. So now we come to realize that diffuse pediatric gliomas are still low grade. And for the high grade, that's really, for pediatric population, there's really no difference between so-called grade 3 and 4, as shown by this important paper by the French group. So really, for the children, it's high grade and low grade. You're all familiar with this histone mutation of H3.3 or H3.1. K27M mutation typifies the midline tumor, which in the past we call DIPG, diffuse infantile pontine glioma. And you appreciate now we have a very good, robust antibody for H3K27M. G34 mutant tumor tends to be GFAP only weakly positive or OLIC2 negative, and may have a little bit of a PNET look. It is a slightly older age group in children and adolescent and young adult disease. And much rarer than H3K27M, and it is highly associated with ATRX and P53 mutation, and the tumor has a poor outcome, as shown by this study by these studies by Cynthia Hawkins and Alan Mackay. Now, then we have this group in children which are IDH wild type and H3 wild type. We know, I forgot to mention that for the children, the gliomas, IDH has no meaning for most cases because they will be IDH wild type. But still, a small number of pediatric high-grade glioma are also H3 wild type. So it's likely that BRAF, NMEK, or other receptor tyrosine kinase or mismatch repair protein mutations are associated with these high-grade gliomas in children which are H3 wild type. A new entity described by two groups, David Solomon's group and Felix Sam's group, of this diffuse midline glioma, usually bilateral, which have a distinct epigenetic signature. I mentioned to you the methylome, and also frequent EGFR mutations in the exon 20. So same lesion described by the German group. And the infantile gliomas are separated out. Infantile usually refers to age below 1, and they often have alterations in ALK, ROS1, NTRK, MET, and these genes usually in the form of fusion. And there are drug trials, clinical trials going on for some of these inhibitors. So two papers simultaneously describing the same result from Cynthia Hawkins and Chris Jones. So polymorphic low-grade neuroepithelial tumor of the young. So an oligodendroglial-like tumor, epileptogenic in children, and characteristically possess CD34 positivity. About 50% of them are BRAF mutated or have other MAP kinase alterations, usually involve FGFR2 or FGFR3. So you can also do, of course, BRAF immunohistochemistry for this tumor, polymorphic low-grade neuroepithelial tumor, young, or sometimes called plenty. Angiocentric glioma is separated out, a grade 1 diffuse glioma characterized in children, characterized by chronic intractable seizures, and this particular genetic event of MYC-QKI fusion, which is not part of the MAP kinase pathway. Diffuse astrocytoma, MYB or MYB-L1 altered. Again, this is not part of the MAP kinase pathway, and previously it was called in the literature isomorphic glioma, and you can see on the right hand side of the panel the cells are somewhat oligoid looking, somewhat round, and diffusely infiltrating the cortex in this instance. Now, I want to sidetrack from the WHO classification a little bit, and I want to highlight to you that BRAF mutation overall is a poor indicator for pediatric low-grade glioma, a very important paper published by Uri Taburi. So we took Taburi's approach further on. Don't worry about the details. We show that the pediatric low glioma can be classified, can be risk stratified into low, intermediate, and high risk group. The definitive paper on this was published by Cynthia Hawkins in Cancer Cell last year. So PLGG, low, intermediate, and high risk group. Remember, PLGG is a very difficult group to treat because these patients survive for a long time, and then they may not be treated very aggressively in the first instance, but then they recur. So the low risk group are those, you may not be able to see the diagram very well, but the low risk group are those which tend to have fusion. The intermediate risk group are those which tend to have mutations, like I mentioned to you, BRAF. And the high risk group include mutations like H3, or in the rare instances, promoter of TERT. There are still a number of genetic lesions where the risk is unknown. So it is very important to keep in mind the overall strategy or approach of diagnosing or molecularly diagnosing pediatric low-grade glioma. Glio-neuronal tumors. So WHO 2021 defines DNET, you're all familiar with DNET, as a cortical circumscribed glio-neuronal tumor with alterations of FGFR1, and there's no change in this lesion. Desmoplastic infantile ganglioglioma, usually a very large tumor, dense desmoplasia, sometimes masquerading meningioma. And then this lesion, which called myxoid glio-neuronal tumor, myxoid glio-neuronal tumor, a tumor typically which looks somewhat like DNET, but a tumor at a septum pellucidum or periventricular region with characteristic mutations of PTGFRA. Diffuse leptomeningeal glioma. This is a case I autopsied many years ago. You can see on the left hand side the tumor diffusely on the surface, just on the surface of the pia arachno on the brain without infiltrating the deep portion. And this tumor may show BRAF fusion or 1P loss, a tumor entirely restricted to the leptomeninges. Papillary glio-neuronal tumor is now defined by PRKCA fusion, which you can do with FISH. The circumscribed astrocytic gliomas are rather like previously. You're all familiar with pilocytic astrocytoma, high-grade, and then we have this new lesion called high-grade astrocytoma with piloid features, PXA, Seeger choroid glioma. Astroblastoma is now defined by MN1 alterations, usually in the form of fusion. You're all familiar with pilocytic astrocytoma, one of the most important astrocytoma glioma to be diagnosed in children, and a big proportion of them is characterized by BRAF fusion, which you can do with a break apart probe, as in this instance. That's what we do. PXA, you're familiar with, is characterized by BRAF mutation and CDKN2A deletion, and of course you can also do the immunohistochemistry. I've never seen this new lesion. This is described by Felix Sam in Germany. Diffuse glio-neuronal tumor with oligodendroglioma-like features and nuclear ducts, a molecularly defined glio-neuronal tumor displaying recurrent monosomy of chromosome 14. So much so for pediatric glioma, which involve a lot of big changes. For adult tumor, for a long time, we are lack of a typical biomarker and rely solely on necrosis and microvascular proliferation. Now, there are a couple of papers, but this is probably the most important one by the German Heidelberg group, in that they show EGFR amplification, combined chromosome 7 gain and 10 loss, and third promoter mutation in a setting of an IDH wild-type astrocytoma will make it, in terms of prognosis, a glioblastoma. So third promoter mutations activate telomerase reverse transcriptase and enable the tumor cells to maintain the telomere, and is usually a terminal event in the life history of the development of the end event, rather, of a life history of the glioblastoma. So these are the other important molecular biomarker is CDKN2A or B homozygous deletion. You can do it by FISH or by methylation profiling. Has been shown in IDH mutant astrocytomas by us and a few other groups that those which deleted in CDKN2AB behave like a glioblastoma. So for adult diffuse gliomas, astrocytoma IDH mutant, we take away the term IDH mutant glioblastoma. Instead, we called it astrocytoma grade 4. And in a setting of a lower grade glioma, homozygous deletion of CDKN2AB is the diagnostic criteria by which you can call a grade 4. No change in oligodendroglioma, 1P19Q co-deleted and IDH mutant. For IDH wild-type astrocytoma, which comprise the bulk of glioblastoma and the bulk of adult gliomas, so EGFR amplification, third promoter mutation, and 7+10- will be the diagnostic criteria for cases of IDH wild-type astrocytoma not fulfilling histological criteria. A lot of people ask me, so what? These are the new diagnostic biomarker for glioblastoma? No, I don't think you should take it to mean that way, that you need to do CTK-N2A and B in every case of grade 4 IDH mutant astrocytoma or IDH mutant glioblastoma when it is obvious. In fact, if you do that, it will put you at a certain risk, because not all IDH mutant glioblastoma are deleted in CTK-N2A/B, as we have shown in this paper. What we were saying, that, as I mentioned, if you have a low-grade IDH mutant astrocytoma that is not obviously histologically glioblastoma and CTK-N2A/B deleted, then you can call this glioblastoma. So in the same vein, it does not mean you need to do EGFR. This PowerPoint does not mean, okay? Does not mean that you do need to do EGFR third or 7 plus or minus for an obvious glioblastoma, which is IDH wild type. What we were saying is that if you have a IDH wild type astrocytoma that is not histologically obviously glioblastoma, if you do any of these and it's positive, then it will behave like a glioblastoma. I am sure if you look at the data set, existing data set, it's similar to the situation in IDH mutant tumors. Not all the regular glioblastoma will have, not all, 100% will have these three biomarkers. There are still many biomarkers which we have not discovered, but if it is a low-grade astrocytoma histologically, and if it shows these biomarkers, then it behaves like a glioblastoma. That's what we were saying. So a histological variant, giant cell glioblastoma, P53 mutations, histological variant like epithelioid glioblastoma, BRAF, ependymomas is now classified by the location, supratentorial ependymoma, with SIFTER, previously we called RELA fusion positive, supratentorial ependymoma, YAP1 fusion positive, posterior fossa ependymoma, which is the most common presentation of ependymoma in children. They are either group A, or sometimes called PFA, or group B, or PFB. Spinal ependymoma, the regular spinal ependymoma, and then the spinal ependymoma, which are MYC amplified. So posterior fossa ependymoma in children divided into PFA and PFB, PFB having a much better prognosis, first described by Stefan Pfister in Heidelberg in Cancer Cell quite a while ago now. And now we have a good, robust immunohistochemical marker, H3K27MU3, the loss of which typifies PFA. PFA is a very mysterious, fascinating ependymoma. It's genomically silent. We are depending on gene expression signature. There's no recurrent, no mutation, no obvious recurrent fusion. It is a very mysterious tumor. RELA, most supratentorial ependymoma are SIFTER or RELA fusion positive and clinically aggressive. Spinal cord ependymomas are mostly low-grade, except when it is endemic amplified. Medulloblastoma are molecularly defined like the 2016 classification, but we appreciate firstly that the sonic hedgehog group can be further divided into p53 wild type and p53 mutant, p53 mutant being of worsened prognosis, and in many instances we are not possible to divide into groups 3 and 4, so we just call them non-wing, non-sonic hedgehog. And we still retain a group similar to 2016 classification of medulloblastoma, histologically defined. I think you should all be familiar with now the molecular classification of medulloblastoma and the histological correlations and the genes involved. So wing medulloblastoma is typified by beta-catenin positivity or mutations in the wing pathway. Sonic hedgehog medulloblastoma, you can use immunochemistry or GAP1 or YAP1 or molecular means. Group 3 medulloblastoma anaplastic type, as in this case with drop metastases and make amplification. This is just to show you the risk classification matters to the clinicians a lot. This is from a paper written by pediatric oncologists in Toronto, which roughly my pediatric oncologists follow their protocol. So you can see the molecular classification and the various genetic alterations are very important in the clinical management of medulloblastoma. IHC cannot distinguish group 3 and 4. In most instances, in most labs in the world, you molecular group medulloblastoma by nanostring transcriptome or methylation profiling. In some places with very clever designing a very clever NGS panel, you can do molecular grouping of by medulloblastoma by NGS. In most instances, you do by transcriptome or methylation profiling. Remember, the medulloblastoma groups were defined by their transcriptomes and not by mutations or RNA fusion gene and so on. So other CNS embryonal tumors, ATRT, cribriform neuroepithelial tumor, embryonal tumor with multilayer rosettes, CNS neuroblastoma, FOXR2 activated CNS tumor with B-core internal tandem duplications. You're all familiar with ATRT, but the SMARCB1 gene loss is also found in some poorly differentiated chordomas and in this lesion called crinets. And the rhabdoid areas may constitute only a small portion of the histological picture. Crinet, cribriform neuroepithelial tumor, is a ventricular tumor characterized by its histological appearance and SMARCB1 mutation. Behavior is still not very certain at this stage because of limited number of reported cases. ETMR is typified by this very special amplicon at chromosome 19, the C19MC amplification, which is made up of microRNA. Meningioma, not much changes in the regular meningiomas, except that all types of meningiomas are described in now one single chapter. So it's not necessary to call something a fibroblastic meningioma, transitional meningioma, and so on. But the more important changes came to the mesenchymal non-meningeal tumors, most of the time attached to the meninges. So solitary fibrous tumor, we discarded the term hemangiopericytoma, rhabdomyosarcoma, and then we have this lesion intracranial mesenchymal tumor, fat crab, sea crab fusion positive, which is defined by the molecular characteristic somewhat similar to its counterpart in the soft tissue. CIC rearranged sarcoma, again, is very similar to its counterpart in the soft tissue, and primary intracranial sarcoma, Dicer mutant in Ewing sarcoma. Some of these lesions were in the past loosely called PNET. As you know, we discarded this term PNET back in 2016. Pineal tumors, pineocytoma, pineal parenchymal tumors of intermediate differentiation, pineoblastoma, papillary tumor of the pineal gland, and then see this how crazy the world has become. SMARCB1 mutant lesion in the pineal gland called desmoplastic myxoid tumor of the pineal region. Tumors of the sellar region, adamantinoma craniopharyngioma, papillary craniopharyngioma, you're all familiar with this. But pituitary-cytoma, granular cell tumor, and spindle cell oncocytoma of the sellar region, we think are probably a single lesion. And then the regular pituitary adenoma and the pituitary blastoma. So I'm sorry this is a bit of a rush because the CNS classification is really very broad, and I would like to finish here, and I'm very happy to take questions during the Q&A session. In my last slide, I'd like to acknowledge my three teachers, Peter Berger, the late Stephen Vogel, and the late Robin O. Barnard. I'd like to thank the grants which have supported my work, Children's Cancer Foundations, the HMRF, and the SKE Foundation. Thank you very much.
The fourth lecture is by Professor Albert Lam, Foundation Chair Professor and Head of Pathology Department, Griffith University, and visiting Senior Specialist of Pathology, Queensland Gold Coast University Hospital. Professor Lam is an anatomical pathologist and a cancer biologist whose research focuses on diagnosis, molecular biology, and treatment of cancers, in particular endocrine, gastrointestinal, as well as head and neck tumors. He is one of the editors of the 5th edition of WHO Classification of Tumors of the Digestive System. Professor Lam is going to talk to us on update of the WHO classification of gastrointestinal tumors.
The topics of my presentation today is on updates on the WHO classification of gastrointestinal tumors. In this lecture, I would like to go through with you the introduction of the 5th edition of the WHO classification of tumor, and will highlight important change in some of the chapters. This is the Gold Coast University Hospital at Gold Coast, Australia, that I did all my research work here. For the 5th edition of the WHO classification of tumor, the digestive system tumor is the first book of the series, and it have already published in 2019. Just alert you, the first edition of the WHO classification of tumor is in 19 60 feet, quite a long time ago. And in this edition, there are several new things. Say, for example, the color of the book is light blue in color. You will make it easy to distinguish from other editions when they are mixed in the bookshelf. In this edition, there's also standardized use of terminology, so that such as the use of dysplasia as low grade and high grade, and also standard use of the international system of unit, like using the millimeter square, replace the high power field. Something I would like to share is that in this series, we have the electronic version, so you can easily look at the book on the screen in your computer or handheld devices with a small subscription fee. And different from the other edition so far, this book have start to have an extended editorial board. What I mean is that in the past edition of the WHO book, there are only a few editors. But you can see from my slides here that starting from this edition, there are standing members and expert members in the editorial board. The standing members are those nominated from different jurisdictions, and they actually involved in the works in different books in the series. And each system, there's some expert that is really have expertise in that series. And the digestive system tumor, we have 11 person on this book, and we met in the WHO office here, and we also discussed the other chapter that we are editing, not the chapter that we edit on our own. Come back to the digestive system, we have 14 sections. And these 14 sections is based on the one section on introduction and 9 section on the epithelial and neuroendocrine tumors of the different location of the digestive tract. And the other non-epithelial and non-epithelial tumor, they are discussed in other separate sections, like the hematolymphoid tumors, mesenchymal tumor, other tumors. And also there's one section on the genetic tumor syndromes of the digestive tract. I will focus on these 9 sections today. For these 9 section, in fact, they are the different topographic region of the digestive system. They all very standardized with an introduction and starting from description of the benign, pre-invasive, and the malignant lesion. This is quite a good move because in the other edition, there are some entities, benign and malignant, mixed together. But now in this series, it start to have these are ordering with benign, pre-invasive, and malignant. And there's never enough time for everything. So in this presentation, I will only concentrate on the section that I have involved in editing. And since this is on gastrointestinal tumor, we don't discuss on hepatobiliary tract. We just concentrate on this system. The green color are those that I have involved in the editing, and the stomach and appendix, the blue color, I also involved in the discussion. First come from the top, the esophagus. In this edition, we have the benign tumor separate, and squamous papilloma is quite a common benign tumor. And then we have the invasive lesion, the Barrett dysplasia, and the esophageal squamous dysplasia. This is quite a controversial term to discuss because some people want to keep the columnar dysplasia, but on also the argument that most of the dysplasia, the corner type is in the esophagus, actually have an etiology of the Barrett esophagus. So both terms should be all right, but we put the Barrett dysplasia at the more favored term. So there are the malignant tumor, malignant carcinoma in this size, and the neuroendocrine neoplasm is also included. In the dysplasia is showing the one thing that we have started to standardize the two-tier grading system, which is more preferable because it's more reproducible and clinically more relevant than the three-tier system. So we use low grade or high grade, and which is important in management because that high grade is normally can be managed by surgical resection. But nowadays that we know that sometimes with the advance of the endoscopic resection, low-grade tumor can also be manipulated by surgical means. Now, we remove the term of mild, moderate, and severe dysplasia, and also we remove the term of carcinoma in situ. For the squamous dysplasia, we also define what does it mean by low grade and high grade instead of mild, moderate, and severe. Low grade squamous dysplasia shows squamous cell with mild cytological atypia and limit to lower half of the squamous epithelium. High grade squamous dysplasia consists of squamous cell with either the cytological atypia involve more than half of the squamous epithelium. But if the dysplasia is the atypia is very high, very severe, no matter how high involved, if we still call it severe a severe cytological dysplasia or high grade dysplasia. Now we move on to the carcinoma, the malignant category. One thing we noticed that in this edition that we actually combine the chapter of the esophagus and the esophagogastric junction because that they actually mostly are of similar etiology of the derived from the Barrett dysplasia. And also from the OG junction, we follow the indication that if the center of the lesion is within 2 centimeters of the junction, we call it carcinoma of the esophagogastric junction. So instead of 5 centimeters, now we narrow down it to 2 centimeters. Now in the adenocarcinoma of the esophagus, the different histological variation are not so prominent. So we don't call it variant, we just call it pattern. And in fact, most often we see is the standard tubular pattern that we see in most of the adenocarcinoma of the GI tract. So we call tubular pattern, and quite uncommon it is arranged in papillary architecture. And sometimes we see mucinous differentiation or Sigley-Weng differentiation, but we don't call it a variant, we call it a pattern. In this series of the WHO classification of tumor, we try to incorporate the molecular techniques of practical use. So HER2 is one because there is approval of the Herceptin. We target the HER2 protein receptor. So we also advise the use of the HER2 immunostaining and also the in situ hybridization test for the increase in HER2. In this new addition, we separate a few tumors outside the squamous cell carcinoma or adenocarcinoma. The esophageal adenocystic carcinoma is the one that we separate out from the adenocarcinoma as a separate chapter. That this is a nice picture contributed by a colleague in Hong Kong, Dr. Yilin Zhang, showing the classical appearance of adenocystic carcinoma by facial appearance, and also showing the epithelial cell and the myoepithelial cell by the immunostain. It's not a difficult diagnosis, and the main thing is differentiate from the basaloid squamous carcinoma type, and which has more squamous cell necrosis and polymitotic figures. But the basaloid squamous carcinoma is negative for actin and S100, which is positive in adenocystic carcinoma. A set of tumor called adenosquamous cell carcinoma and mucoepidermal carcinoma now is separate out, because that one thing is that we can't actually define that whether this tumor is a group from the squamous cell carcinoma or from adenocarcinoma. Some may arise from esophageal gland ducts, and some may arise from epithelium. So we will put that in a separate chapter. And by definition, adenocarcinoma, the squamous and the columnar region are separate. But for the mucoepidermal carcinoma, the squamous and the columnar region, the granular region, are mixed. Come back to the most common cancer, the squamous cell carcinoma. These are the variants: the conventional, the verrucous, the spindle, and the basaloid squamous. The basaloid squamous is defined as a tumor composed of basaloid cell and also a squamous component. They are very distinct, and which is the main differentiation from fully differentiated carcinoma, and of relatively poor prognosis as compared with conventional squamous cell carcinoma. The other one that may of interest is the spindle cell squamous cell carcinoma, which is usually polypoid in appearance with spindle or sarcomatoid-like tumor cells. The importance of identifying this is to identify the epithelial component, like this high-grade dysplasia component here, to make sure that this is a squamous cell carcinoma rather than a sarcoma. Undifferentiated carcinoma is also now considered as a distinct entity rather than a subtype of squamous cell carcinoma. It is a carcinoma lacking the squamous or the granular or neuroendocrine differentiation. And there are variants of this, like those with loss of SMARC expression, as well as the P53 mutation. And that is also included in this variant, the EBV type, that with a lymphoid stroma. One thing important in this addition in the GI tract is about the adjuvant therapy. Because nowadays, there are a lot of the tumor come to resection, have the adjuvant therapy, chemotherapy, or radiotherapy, or both before the operation. And we need to know that there are many changes that is accompanying the therapy, and sometimes very difficult to find the tumor cells. Say, for example, in here, that is all tumor giant cells in fibrotic background, and this is tumor cell within the mucinous matrix. That is those degenerative change, and those are the thick wall vessels. One thing important is to have a system, because that many studies have shown that the response is related to somewhat prognostic, have prognostic value, or tumor with chance of recurrence. There are many systems. No one can prove that any system is better than the others. And in esophagus and stomach, we have the system of this. One is the actually looking at the relative proportion of fibrosis and the carcinoma cells, and the other is looking at the percentage of carcinoma remained. And no one is better than the other, but we recommend that you stick with one system with your clinician so that useful information can be given to your clinician. We move to the stomach. That stomach have a lot of different subtypes, and you can see here that in the here that the adenocarcinoma is the main subtype. Then you have the different variant like the most common tubular, papillary, and the fully cohesive, that means the six-leg ring cells type, and the others, fully cohesive carcinoma and the Mucus adenocarcinoma. There are other one that is not so common, including the carcinoma with lymphoid stroma. The WHO actually also give the molecular classification, which is quite relevant, that the EBV subtype is EBV positive, and there's a classification using the microsatellite instability. There's a group of carcinoma that is have showing the microsatellite instability, and there's a group of genomic stable that is by morphology is the fully cohesive type, the six-leg ring type, and the majority, half of the tumor is actually the convention of tubular and papillary type. And it's important to know that actually this EBV and the MSF type has a better prognosis and have candidate for immunotherapy. Appendix, the most important change in that we do not use the term carcinoid or gallbladder cell carcinoid anymore. We use the term gallbladder cell adenocarcinoma for this type of tumor that have some neuroendocrine differentiation, but mainly the property is similar to adenocarcinoma. One important highlight is the mucinous neoplasm, the low grade and high grade mucinous neoplasm we call LAM, but they are common and usually of low grade rather than high grade. In the colon and rectum, this is the, of course, a very common entities, categories of entities. And even for the benign neoplastic category, there's a much changes. And we all know that there's a change in the lesion called colorectal serrated lesions and polyps. And there's a new chapter of the inflammatory bowel disease associated dysplasia. I think this all worth a few lectures on it, so I will only briefly introduce on that. For the serrated lesion, we're showing the serrated lesion here, that this is a new classification, that the hyperplastic polyp, we retain the microvascular and gallbladder cell rich type, and the mucin pool type have been removed. For the sessile serrated polyp and adenoma, people replace it with sessile serrated lesion SSL and sessile serrated lesion with dysplasia. Although this is a big argument and many people are against it, but I know that the gastroenterologists all have make note of that, and that should not be any problem. There's also the traditional serrated adenoma, and also there's a category of unclassified serrated adenoma. So this is the hyperplastic polyp, this one is the sessile serrated lesion with the bush-shaped dilated crypts, and this is the traditional serrated adenoma. One thing different is that in the last edition, we required this bush-shaped or anchor-shaped dilated base for 3 crypts having that. But in the 2019 edition, we only need 1 crypt. But the histology of this crypt should be very unequivocal, so must be very definite. And one thing to note that we are not going to, on one hand, we are not going to miss the diagnosis of sessile serrated lesion because it has a implication of the follow-up of the patient. But we don't also underdiagnose or overdiagnose. So the size of the tumor for a hyperplastic polyp is seldom more than 10 millimeter. So if a hyperplastic polyp more than 10 millimeter clinically, you probably look hard for the whether it's a sessile serrated lesion. And dysphasia in the sessile serrated lesion is already an important criteria for a closer follow-up. So we don't need to actually concern that whether the sessile serration have high grade or low grade lesion. And sessile serration lesion is mostly on the on one hand the BRAF mutated pathway, and the sessile serrated adenoma is mostly on the RAS pathway. Coming to the carcinoma, these are the variants adopted. I think the more common is the mucinous, the cingulate wing cell, and the medullary carcinoma that have a worth a bit of mention because that it actually identifies a shift of malignant cell with vascular nuclei, prominent nucleoli, and abundant eosinocytosome, and with infiltration of lymphocyte and neutrophil in the stroma. It actually looks like an undifferentiated carcinoma. But the main thing is actually this kind of medullary carcinoma is microsatellite high, unstable. So we can actually always do a MSI to differentiate. There are other entities, and some of that just change of term, like the spindle cell carcinoma the term have been removed and replaced by carcinoma with sarcomatoid component, and the villus adenocarcinoma replaced by adenoma-like adenocarcinoma. For the pathogenesis of colorectal carcinoma, we all know about the adenoma and carcinoma progression pathway, but we also highlight that there's a serrated pathway for the progress. There are a chapter about the hereditary syndrome, actually a few chapters about the hereditary syndrome with different progression, like the Lean syndrome, like the family adenomatous polyposis. And one thing of important is the inflammatory bowel disease, which is increasing incidence in both in the East and the West. And there's a chapter of the dysplasia related to that. For the pathogenesis, we also aware of that the mycobacteria in the gut is altered and is important in the pathogenesis. And also there's a renewed interest about how the meat consumption will lead to high prevalence of colorectal cancer. There are a few tests that we often have to involve in the reporting for colorectal cancer, not only to classify the tumor along the pathogenesis, but actually have some prognostic use or treatment related. Say, for example, microsatellite instability by immunohistochemistry. It's present in around 50% of the colorectal cancer. And in my working area, we have done the microsatellite instability for every tumor from the colorectum, and around 70%. So it's quite a figure that we would like to remember. Microsatellite stability is also important. We know that there's loss in one of the marker MLH1 in the SSL with dysplasia, and we all know that this is used for screening of Lynch syndrome. In BAF wild type tumor, MSI tumor has actually better prognosis. But on the other hand, the MSI high reduce the benefit of uracil-based chemotherapy. And now, because of the immunotherapy, we know that there's a significant relationship between the MSI and PD-L1 expression when we want to use to predict the PD-L inhibitor response. This is the procedure for highlighting the use of the MSI. And in my department, actually, we take a board for the MSI to decrease the turnaround time so that we can have a block for the MSI so that when the sites come to my desk, we already have the tumor histology and also have the MSI expression. And the most common MSI high is actually the loss of MSH1 and PMS2. And we can see that this is a loss in expression and highlighted by the background lymphocyte, which is positive. And the same block, we can actually highlight that and select for mutation analysis. The other mutation commonly employed is RAS mutation, the KRAS and NRAS, because they are downstream on the growth factor receptor, and that is the monoclonal antibody that target to in the target therapy. So that when they are mutated, the marker, the monoclonal antibodies cytoxamides usually do not work. So a test of the RAS and KRAS is important in a patient with metastatic cancer that would follow up by target therapy. The other marker is BRAF, and we know that is used to detect whether the patient have Lynch syndrome or not, in case the patient have MSI high. And BRAF V600E is the most common variant, but there are other variants that exist. And these variants actually are mutually exclusive to RAS mutation. So sometimes that we already know that if BRAF have done, we know the RAS status. There is a strong correlation with serrated lesion pathway to neoplasia, as we already mentioned before. And it's also a marker of poor prognosis. Unfortunately, although that there are multiple clinical trials targeting the BRAF for therapy, but none of any success. The BRAF mutation happen in around in different figures throughout the world, but I think that overall, except a few areas, the figures is less than 10%, especially in the Asian area, that normally the expression of the BRAF mutation is much less. Then we come to the very end, the anal canal. And I actually, as opposed to the previous edition, I rewrote the introduction, define the histology and the anatomy of the anal canal, which is around 3 to 5 centimeter, and the dentate line is around 1 to 2 centimeter distal to the anorectal junction. Now, we need to aware about the anatomy of the tumor if it occurs in the anal canal. The benign Anal canal epitheliation are usually removed by endoscopic examination, but the malignant lesion is difficult to operate and usually treated by chemotherapy and radiotherapy. And the perianal lesion, they are outside, they are treated as a skin lesion. These are the entities from benign to malignant, and we add also the common benign entity as a separate chapter, like the inflammatory coagulogenic polyp and the anal condyloma. And the pervasive lesion is the AIN, or the anal squamous dysplasia. We also include the very rare anal neuroendocrine neoplasm in this section, beside the more common squamous adenocarcinoma. For the P-invasive lesion, again, we use the two-grade system. We favor the 2T system, the low-grade SIL, that means the AIN1 and AIN1 and the coordinoma with dysplasia, and the high-grade SIL mean the AIN 2 and 3. It defines a marked cytological atypia involving at least 2/3 of the anal squamous epithelium with mitotic figures in the upper 2/3 of the epithelium and loss of nuclear polarity. And we stress the importance of the HPV, as in the cervical cancer, and the P16 can be, as a reflection of the HPV infection, can be used to identify the high-grade SIL. For the malignant tumor, the squamous cell carcinoma is the most common, and it's often of the basinoid squamous differentiation. So as it's near to the skin, anal skin, so it's important to differentiate from the basal cell carcinoma. And the BCC is PEREB4, small actin and BCL2 positive and negative, and the SCC are negative for this. And in contrast, SCC is positive for EMA and negative from the above mentioned markers. The other tumor is the adenocarcinoma. Adenocarcinoma can actually, you can see in here that actually also have patches cells, tumor cells there, but it can occur in both primary and secondary adenocarcinoma. Primary means arise from the anal canal, and secondary means spread from the other organs. And the primary adenocarcinoma can be mucosal origin. That means that can be CK20 positive, or may arise from the anal glands, that is CK20 negative, fistula, or other congenital abnormalities. And there's a picture in the WHO how to differentiate the various types by clinical and by markers. Then we move on to outside a bit to the pancreas. This is the last organ that I would like to go through with you. But I won't go through the epithelial tumor. And the one thing I'll look is again for the dysplasia here, we use the high grade and low grade. I will put most of the time on the neuroendocrine neoplasm for the pancreas, using the pancreas, but also is applicable to the other part of the digestive tract. This is one of the things that, one of the areas that actually have a major change in the compared with the other addition in the recent years. And in summary, the pancreatic neuroendocrine neoplasm is divided into 3 categories. One is the neuroendocrine tumor, or PANNET, and it divides into 3 grades. The other is the neuroendocrine carcinoma, the NEC, and the mixed tumor. And the mixed tumor is based on the 30% of each component, the neuroendocrine component and the non-neuroendocrine component, except small cell carcinoma, once it's present, is important, no matter how many percentage. And this differentiation is based on the mitotic weight, P67, the morphological features, and the coexisting tumor type. So this summarizes the foundation of this classification. For the benign end, the more benign end, but it's not benign, is the PNET, the neuroendocrine tumor. It classifies a difference from the other neuroendocrine tumor. It classifies also along the hormonal syndromes. So it can be classified non-functional and the functional one, like the insulinoma, carcinoma, lipoma, etc. And they have the classification based on the hormonal production and the clinical manifestation and association with hereditary syndrome. I summarize in this table the different clinical pathological features of the this NET. So you can see here that most common is still the non-functioning, followed by the insulinoma, and the other are quite less common. And you can read about the classical features and also the association of genetic syndrome in this table that I given in the handout for you. The other thing I would like to highlight is about the difference between the neuroendocrine tumor and the neuroendocrine carcinoma. The neuroendocrine carcinoma is also further divided into large cell and the small cell carcinoma. The neuroendocrine tumor is more on the trabecular shape and of low P67 and mitotic index. And the neuroendocrine carcinoma is very atypical looking, and the P67 index is nearly always more than 90%. And it is not sure that there are markers like P53 and retinoblastoma that can differentiate the neuroendocrine carcinoma for high-grade neuroendocrine tumor. Now, we now know that starting from a few years ago, there's a grade 3 neuroendocrine tumor that for the tumor that more than 20% P60 index, 67 index, and more than 20 mitosis per 2 millimeter square. So this is the classification for the grade 3 neuroendocrine tumor. But we also need to, from the morphology, how this grade 3 is different from the neuroendocrine carcinoma. Why is that important? Because previously, when we have the high mitotic index and high P67 index, we moved that to neuroendocrine carcinoma. But in fact, this is an over-treatment because neuroendocrine carcinoma, like small cell carcinoma and large cell carcinoma, they actually deserve more aggressive treatment. This is how the different neuroendocrine neoplasm being managed on a management point of view. And of course, the curative surgery is the main treatment. And for the neuroendocrine carcinoma, the platinum-based regime, the standard chemotherapy, are used as a standard treatment. But the neuroendocrine tumor grade 3 and also other neuroendocrine tumor, the treatment are different. Now, these are the books I have from the WHO, starting from my early practice. I don't have the first edition, but I have all these actually up in my bookshelf, that I can see that from the different edition, how the evolution of the classification of neuroendocrine neoplasm. In the 1980s, the second edition, if some of you have this in your department bookshelf, they are only a few sentences giving a definition. And the start of the greater detail is in the third edition that I was first involved in the endocrine system. And in the GI system, in the fourth edition, and in the third edition, actually there's no mention of the pancreatic neuroendocrine neoplasm. The first mention of that is actually in the fourth edition in the 2010. And up to 2017, for the fourth edition of the endocrine system, that is the current classification in shape. And we have only a mild modification in the fifth edition that published actually a year later for the digestive system. So this is the evolution of, if you want to see the change about the classification, you can get this book, but actually I summarize for you here in this publication how the change have been done. Now, in the 2017, in the endocrine book, the fourth edition, we first add the grade 3 as the reason that I have already mentioned. And also we define well the different entities of the mixed neuroendocrine and non-neuroendocrine neoplasm. And also it increased the mitotic figures and the key 66 7 guideline from 2 to 3 that you can read about that is a silent change from 2 to 3. In the 2019, everyone probably know that we changed the high power field, the 10 high power field to per 2 millimeters square. The other very silent change that you need to read carefully is that in the 2017, we used the mitotic count and Ki67 as all. But in this new edition, we did both. We use the term N. And also we actually have an abbreviation of this mixed endocrine tumor. So we call it MINEN. And also we involve the benign, not benign, the more better prognosis tumor, neuroendocrine tumor. In the mixed category, if there's a coexistence of the epithelial entity. So we add one more entity of the mixed tumor. So that's come to the end of my presentation. And I summarize for you that in some of the things that we have starting from this edition on and follow is the standardization of the terminology such as the high grade and low grade dysplasia, the neuroendocrine neoplasm. And also because of this new WHO classification, we have moved into the standard reporting, the international reporting for cancer, and you can easily find the website that different cancer now have an international protocol. In this edition, we also have an incorporation of many useful molecular tests, and we need to be aware of the effect of the treatments. And this is not, of course, the final edition because I think that it still have a continued evolution and updates. So because this new double edition series, although despite the COVID, is actually still progressing, and the chair think that the series need to review every 5 years. And these are the reference, the key reference that I actually many of the tables beside the WHO, they are actually used for all these reference. And this just highlight to you that the things I have learned through my years of career in the third edition to the fifth edition that I'm involved in this WHO classification of tumor, and I've learned a lot from actual experts from throughout the world. And thank you.
Ladies and gentlemen, we are now getting on to our last part of this session today, which is the Q&A. We have now all of our four speakers here with us in our Zoom meeting. So we have Professors Alfred Lam from Australia, HK Ng from Hong Kong, Keith Kerr from Aberdeen, UK, and Adrian Flanagan, also from the UK. We have all listened to the excellent presentations on updates on the W2 classifications, on the GI tract, on the central nervous system, on the lung tumors, as well as on bone and soft tissue, and particularly on the bone part of the classification. We're now starting, so if you have any questions, you're very welcome to send in the questions to us using the chat function on the Zoom, and also in the YouTube as well. So we'll begin with Adrian, maybe. Adrian?
Okay, yeah, I'm
Okay.
here.
There are a couple of questions. The first one is, how common do we see chondrosarcoma of the nasal bridge?
Extremely uncommon. I suspect that they could be seen by mainly the head and neck pathologists, but these lesions are extremely uncommon.
Okay, it's a very short answer. Thank you. Very definitive answer. Okay, in the new WHO textbook, there's a lot of molecular classifications. How can this be applied to the countries that lack molecular testing? What's the function of molecular testing, and should the clinicians know about molecular testings as well?
Okay, this is a slightly longer answer. So the diagnosis and the prognosis that we give to patients with bone tumors still largely relies on the morphology, the imaging, the medical imaging, the radiology, and the clinical context. What molecular pathology has done has really helped help us define. For example, we now know that you rarely, if ever, see a giant cell tumor of bone in the jaw bones. For instance, you virtually never see a chondroblastoma in the jaw bones. This now has helped us define this, and moving forward, one doesn't really need to do the molecular biology. We've also been very lucky that in many cases, for many findings, we now have antibodies. So you can apply antibodies rather than the classical molecular analysis of nucleic acid for many of the bone tumors. Let's take another example. Distinguishing a small round blue cell tumor in bone, clearly you need to exclude a lymphoma or leukemia. You can do that with immunohistochemistry. If you're working in the MD Anderson or such institute, you will do a lot of molecular work with genomic analysis and FISH. But actually, if you don't have all of that information, it's not that critical, because once you've defined that it's a Ewing's or a B-core or a Chick-Duck's rearrangement, the standard of care is still the same. But you have to still exclude that it's a lymphoma or some other rhabdomyosarcoma or some other round cell tumor. So actually, on a practical level today, it's still basic morphology and basic sensible immunohistochemistry. And you have to continually ask yourself, what treatment, how is this going to affect the patient's treatment? That's all you need to ask. And if you say it's around, if you've excluded lymphoma, leukemia, rhabdo, you're then saying it's a Ewing's type sarcoma and the patient will get the same treatment. One needs to be highly pragmatic. Where it does help as well, we now know if you had the sophisticated molecular, the patients with a Chick-Duck's rearrangement, the clinical outcome for those patients is considerably worse than if you have a Fly1 rearrangement with EWSR1. But the clinical treatment is the same. So one has to tailor one's communication with the patient and with your clinicians on the basis of what you have to offer. Where molecular pathology is very valuable particularly for young people, and I'm talking about people under the age of 30 with sarcoma or bone and soft tissue lesions, always consider the potential for a germline alteration. I think this has profound consequences for the families and for the individual. So many young people with an osteosarcoma, or almost any sarcoma, one should consider whether this is potentially a familial disease. That will change the discussion with the families and the long-term prognosis for those patients. So genetic information, we should also think more globally about the family consequences rather than what do we do just today. So leaf Fraumeni is not uncommon in young people with sarcoma. Neurofibromatosis, it's very important, those overlapping syndromes with neurofibromatosis, Noonan syndrome, cherubism, all of these lesions of the gnathic bones, it's very important to think about germline alterations. So today, if you don't have sophisticated molecular pathology, it should not make a difference, provided you are aware of the potential differential diagnoses and excluding those with immunohistochemistry, and then having sensible conversations with your clinicians and the clinical context. A couple of situations where molecular can be helpful. Osteosarcoma, always look at the radiology and discuss that with your radiologist. It still can remain challenging at times, but you can exclude an aneurysmal bone cyst with FISH using a USP6 rearrangement. A FOSS rearrangement can also be helpful for an osteoblastoma to distinguish between an osteosarcoma. But none of these things are absolutely specific or sensitive. So you must really interpret it on the basis of the histology, the radiology, and the clinical context. Molecular diagnosis on its own is a dangerous thing to think of. I've also, just very briefly, I've seen that there's a question about methylation profiling in terms of brain tumors. There are now papers coming out about methylation profiling in bone and soft tissue tumors. I would advise tremendous caution. This could prove very useful in the future, but it is not safe to use or sensible to use methylation profile for bone and soft tissue tumors today. Thank you.
Thank you, Adrian, for very insightful answer to this question, which is very relevant to many of our audiences at this point. I would like to shift gear and ask HK, basically the same concept. In being tumors, we always talk about a lot of molecular testings for diagnosis. And how about in resource poor countries, institutions? What could we do?
Not sure I have the answer to this question.
Sorry, can you speak louder?
Can you hear? Am I mute?
Your voice is still a bit soft. HK, please unmute. You need to unmute. HK. Lisa, HK.
嗱，OK，頭先我 unmute 唔到喎，聽唔聽到啊？而家聽唔到啊？
而家聽
頭先 unmute 唔到喎，唔知點解。Now it's okay. So I'm not sure I should answer the question. I am the best person to answer the question. I appreciate one of my PowerPoint is you don't like the don't like the classification, don't shoot the messenger. I think a lot of the entities as described in the new WHO classification are molecular diagnosis. Basically, it's not possible to diagnose them unless you have certain gears. I think one of the reasons should be for one of the what the panel thinks is once this is publicized, and everyone should try to gear up their resource as much as possible. But I have no answer to these questions, so I'm not sure it's for me to answer. I agree, some of these diagnoses are rather difficult without good resources.
Okay, perhaps we'll ask some friends to send the case over to you. Another question, are there any IHC surrogate markers available for GBM, various genetic abnormalities? For example, EGFR amplification, third promoter, CDK2A deletion, etc. Are there any other or any reliable IHC surrogates that we can use instead of molecular testing?
So I try to emphasize in the lecture that those are not markers you must use in the diagnosis of a regular GBM. So you can diagnose GBM, as I do every day, based on simple histology. But EGFR third and 7+10- are the criteria when you're faced with a low-grade IDH wild-type astrocytoma. Then if they exhibit these markers, you can call them glioblastoma. So they are not absolute necessary criteria for diagnosing a regular GBM. Now, are there any other markers? I'm sure. I am absolutely certain that there will be the markers that lie outside what is currently described as glioblastoma marker. For example, we've shown like an IDH wild-type astrocytoma, CDKN2A only account. If you look at a bunch of IDH mutant glioblastoma, CDKN2A homozygous deletion will only account for about 60% or less than that, 50% of all IDH mutant glioblastoma. I'm sure in time people will show, if you take a series of IDH wild-type glioblastoma, EGFR third and 7+10- will only account for a certain percentage. It will not account all percentage, all glioblastoma. So I'm sure further markers will come, and I encourage you to diagnose glioblastoma, which is an easy diagnosis in your usual way if the histology is straightforward and the imaging is straightforward, and then you don't need me to diagnose glioblastoma, the regular garden type of glioblastoma.
Thank you, HK.
Thank you, Professor Ng. Thank you, Professor Ng. There's another question for Professor Lam. Professor Lam, do you routinely do MSI testing on gastric cancer?
In my practice here, of course, that we do a routine MSI on the colorectal cancer because they are there is related to the treatment requirement. As I highlighted in the gastric tumor, that MSI have some prognostic implication, but in my routine practice, unless required, I won't normally put that as a standard for the gastric cancer, but only for the colorectal cancer.
I see. Thank you. Okay. There's a second question on assessing dysplasia in sessile serrated lesion. What is your advice on doing MLH1 immunostaining?
I think that for the SSL with dysplasia, one thing is quite rare, and we need to actually use our normal standard that to differentiate between dysplasia or not dysplasia. And the MLH1 is not quite helpful because that even if SSL with dysplasia, sometimes the MLH1 is not present. But what my advice is, we have as a SSL with dysplasia, we definitely must do MLH1.
Alfred, there's one more question for you. In assessing or grading neuroendocrine tumors, what are the criteria? Because we understand that grading is not uniform for NETs over different organ systems. So as a multi-organ expert, what would be your view on how should we grade our NETs?
Actually, I think that it will now. What I can familiar is of course the GI system, and also the endocrine system, because that the endocrine system, even the pituitary, are also sorry, HK, probably you know more than me, is moving also to the the neuroendocrine tumor. What I hear from the other speaker Keith here is also that actually the neuroendocrine tumor, they use a bit of different terms, but it's still that we likely to remove the carcinoma. We use the neuroendocrine tumor term. This is one thing, no matter what system. And there's another term that neuroendocrine carcinoma, small cell and large cell, is also universal things. The mixed tumor, maybe people is using from different system, but it's still that is according to the general tendency that we have a category of mixed tumor. The most important is actually the neuroendocrine tumor. In the GI, that we actually grade it, but the grading is more or less similar to other systems. Say, for example, in other speaker, the neuroendocrine tumor and the atypical carcinoma, we actually use the similar system about the mitotic figure and the Ki67 index. The most important, of course, that now is that we count the mitotic figure and also we count the Ki67 index appropriately. That is the things that we will go on in further classification to have a very standardized way to define this entity. Again, is for the treatment aspect.
Thank you. Keith, some questions that I'm relaying from the audience. The first question is, how can we differentiate solid pattern adenocarcinoma with pseudosquamous appearance of adenosquamous, particularly, let's say, in a small biopsy or hypothetically in cases where they don't have a lot of IHCs? Basing on morphology alone, can we do that? Or we just say?
So Gary, I didn't quite catch the question. How can we distinguish adenosquamous carcinoma from what?
From an adenocarcinoma with a solid pattern.
Adenocarcinoma with a solid pattern.
Yeah, do you make
from adenosquamous carcinoma?
Yeah.
Yeah, okay. So, well, the distinction between those two entities, firstly, we have to be speaking about the distinction in a surgically resected tumor. So that would be the first context to emphasize. And one can only make a diagnosis of adenosquamous carcinoma if there is definitive evidence of both squamous differentiation and glandular differentiation in at least 10% of the lesion. So a diagnosis of adenosquamous carcinoma requires that at least 10% of the tumor has squamous differentiation. And if you're not going to use immunohistochemistry, and I can briefly come to that in a second, on morphological grounds, you must see definitive H&E evidence of squamous cancer on the basis of keratinization and or intercellular bridges. And if you do not see those morphological features, you're not entitled to make a diagnosis of squamous cell carcinoma. We've been troubled, and I guess this is the same in many different systems, with this concept of squamoid looking areas of tumor, which is a very, very subjective assessment and has been proven by other methodology, including immunohistochemistry, to actually be very flawed. Bill Travis wrote a paper a few years ago about tumors that had a squamoid appearance, but many of them turned out to be adenocarcinomas on the basis of their immunohistochemistry or molecular features. So if we are strict about the diagnosis of squamous carcinoma, then a diagnosis of adenosquamous carcinoma probably actually is a relatively uncommon tumor. If you do not have access to immunohistochemistry, I'm not sure that I would panic too much about this. I definitely fall into the pragmatic group of pathologists that has been invoked by some of the other speakers already, in that the clinical significance of making a diagnosis of adenosquamous as opposed to solid pattern adenocarcinoma is actually zero. So it's not something I would worry very much about, to be honest. And one of my concerns, thinking about what HK said about don't shoot the messenger, one of my concerns about bringing in immunohistochemical features into the definitions of tumors, and this goes back beyond the new 5th edition of WHO classification, is bringing in immunohistochemistry into definitions really opens Pandora's box for all sorts of variation according to different laboratories' immunohistochemistry. So we like to think our immunohistochemistry is more objective, but I'm actually not sure that that is true. So I hope that addresses some of the points, at least in the question.
Thank you, Keith. This is, I think, a lot of wisdom in this, and we can take home and throw away all our immunohistochemistry. Another question is, at the frozen section, when we see a tumor or a lesion with mild to moderately pleomorphic nuclei, but the lesion, the cells show a lipidic pattern. How should we differentiate whether this is a reactive change or this is like a low-grade lipidic type of adenocarcinoma? Can we be very accurate? And this is really a fairly common problem. What's your
Yeah,
advice on
this is a hugely difficult problem, and I have been caught out myself by this this situation. Not so much when there is a lot of atypia, but when the atypia is relatively low grade, it can be extraordinarily difficult, if not impossible, to distinguish a lipidic pattern adenocarcinoma from reactive hyperplasia. So there are one or two basic principles that you know, nothing new and nothing magic. If there is evidence of an inflammatory process in the frozen section, particularly in the interstitium, you would have to be a little bit more cautious if you are concerned this might be reactive. The problem there is that lipidic pattern adenocarcinomas quite often also have inflammation in the interstitium. The second thing is, if the cell population, the alveolar lining population, is more monotonous, one would be a little bit more concerned about a reactive condition. And depending on the quality of your frozen section, if the cell morphology is more hobnailed, I think this is more worrying for neoplastic disease. Very often, reactive hyperplasia, the type 2 pneumocytes tend to be a bit more flat topped, so that you get a more even lining of alveolar pneumocytes. But you know, everything has to be taken in context, and you know, some dialogue with the surgeon, even if you have access to the CT scan. But at the end of the day, sometimes this is an impossible call, and I think the role of the pathologist is, and it's a very hard thing to say for us pathologists, that you have to just say, I don't know.
So in this sort of situation, have you personally ever deferred the diagnosis?
Yes.
So then we don't feel too bad doing it, right?
No, I mean, I think that this idea that you must always give a diagnosis is a very dangerous one.
Thank you, Keith. One last question for you. Is type switching after TKI therapy in adenocarcinoma considered part of the spectrum of adenosquamous carcinoma?
So what kind of therapy?
TKI, tyrosine kinase inhibitor.
TKI therapy.
Yeah.
Well, absolutely. If you make a diagnosis of adenosquamous carcinoma, or any carcinoma which has an adenocarcinoma component, so you know, an adenocarcinoma, an adenosquamous carcinoma, or an adenocarcinoma that's mixed with another type of tumor, for example, large cell neuroendocrine carcinoma. This combination is not uncommon. Then the guidelines say that we should test those cases for targetable therapeutic alterations. And if an alteration is present, and we know from data that in adenosquamous carcinomas in particular, EGFR mutations are relatively common. They're probably not as common as in pure adenocarcinomas, but they're still present. And if you look in the trial data from groups of patients who've been treated with EGFR TKIs, there are usually some adenosquamous carcinoma diagnoses in those trials. Now, how they made that diagnosis is another question, but I'm not going to get into that one right now. But absolutely, these patients are candidates for testing, And if they have the target, it's appropriate to treat them.
Okay, so it's more important to have the testing rather than the diagnostic label in terms of treatment, right?
Yes, because the TKI treatment is predicated on the presence of the target, and oncologists should never ever be giving these drugs in the absence of the appropriate test. In many countries, it's not you're not allowed. It's not approved to give the drugs unless the target is present.
Okay, thank you very much, Keith. And I think the time is running out, and we will stop our session, Q&A session here at this point. I would like to, on behalf of the AAPIP and the Hong Kong IAP, thank all the speakers for their participation, for the lecture, as well as joining us real time for this Q&A session, and for the very wise advice that we were given at this point. And I would also like to thank all the registrants and the organizing team for this activity. Thank you very much, and enjoy the rest of the day, whether it's the morning or afternoon. Thank you. Bye-bye.
Thank you
Thank you very much. Bye-bye.
Bye.
Bye, everybody.